everyone. Welcome to Preemie Chats. Preemie Chats is a program that is for healthcare professionals and parents to talk about what matters most to you, to explore new ideas, and to learn together. I'm Leah Whitehead. I'm the proud mom of a preemie and a former journalist, and I'm happy to be your host today from Halifax, Nova Scotia. Preemie Chats was created and is put on by the Canadian Premature Babies Foundation, also well known as CPBF. The foundation is a parent-led charitable organization that helps families in and after NICU through education, support, and advocacy. If you have a heart for preemies, whether you're a healthcare professional or a family, I'd invite you to head over to CanadianPreemies.org, and there you will find lots of resources, the latest projects, and most importantly, a community of people who want to see our little ones thrive. Today's session is live, so I'd invite you to please bring your voice to the table. Leave comments and questions in the chat, and we'll try to address them during our time together. It is through rich conversations like these where we can advance practice and learn together. So please participate and let us know where you're watching from. Our topic today is one that I personally experienced with my first baby at 27 weeks, the preterm premature rupture of the membranes, or PPROM, as you may know it. I remember it being very scary for me, and I didn't know at the time that it didn't mean I was delivering my baby right away. Today, I think we're all going to be leaving with a better understanding of this condition as we increase our understanding of what it is, how it's diagnosed, effective management, and we'll hear about exciting developments in PPROM research. I know families can sometimes be worried that if it's happened once, it'll happen again. And so we're also going to hear some tips and strategies for managing future pregnancies. I'm going to be joined by two amazing people who are well-versed in the world of PPROM. Dr. Isabelle Boucoiran and Dr. Stefania Ronzoni. Sorry for butchering your names, ladies. Dr. Isabelle Boucoiran is a clinical associate professor at Université de Montréal, or you might know it as UDM. She is a mid-career clinician scientist at the School of Public Health of UDM and the Obstetrics and Gynecology Department of St. Justine Hospital, where she is co-director of the Women and Children Infectious Disease Center, or CIME. She'll be joined by Dr. Stefania Ronzoni. She's an associate professor at the University of Toronto and clinical investigator, maternal fetal specialist at Mount Sinai Hospital in the Department of Obstetrics and Gynecology and Ontario Fetal Center in Toronto. She is the co-lead of the Preterm Birth and Prevention Program. So I'd invite you to join me in welcoming them to the stage today. Thank you both for being here.
Thank you.
Thank you for the invitation.
Thank you.
I'll let you get right to your presentation today.
Good morning, good afternoon, depending on where you are in Canada. So we're going to effectively present our information on navigating PPROM, strategy for management, future research, and supporting future pregnancy. We are also looking forward to hearing your comments or your questions. Quickly, we're going to go over an overview of what is PPROM and how it impacts preterm birth rate and the child outcome, so your babies. How we do the diagnose PPROM and the development in PPROM research, because Stefania and I, we are working together on several projects related to PPROM. And finally, we're going to discuss the management of future pregnancies.
Okay, I'm going to start introducing the topic and try to understand and talk about the same thing. What is actually PPROM? Technically, it's the spontaneous rupture of the membrane. So more commonly, it's nominated as, oh, my water break. And this is premature because it happens before 37 weeks, and pre-labor because it starts without contractions and before the labor starts. It's a complication of pregnancy that contributed for 3%, but in reality, it's actually more important, the contribution of preterm birth, because it's responsible of about more than 30% of all pre-PROM. The problem is that it's associated with a very high neonatal mortality and short and also long-term severe neonatal morbidity. The role of the fetal membranes is actually very important. And the fetal membranes are just not one single layer. As you can see on the right, there are multiple different layers that constitute the membranes that are particularly formed by amnion and chorion, and they are very well attached to the decidua, that is the internal part of the maternal uterus. They have the specific function to protect the fetus by guaranteeing a sterile environment, and so they are a good barrier for microbial access. They have also an immune protection, and also they have a mechanical protection because they guarantee a certain amount of fluid around the baby. And they also express some biomarkers that are, in a positive way, generally, markers that determine the good function of the fetal membrane. The problem is that PPROM is not a single disease, as you can see. This is a very complicated figure, but the purpose of showing you this figure is just to tell you that PPROM is generally the end of multiple events. And the problem for us physicians is that these events can cause PPROM in isolation, but also in combinations. And so most of the time, even if you think that you are a mother with PPROM, this doesn't mean that you are exactly the same mother of your friends that had PPROM, because the causes that ended up with PPROM are many. And this is why we are challenged every day to try to understand exactly why this happened. What we do when we have a mother with PPROM is kind of a standardized consultation. And I'm sure that if many of you had this bad experience, you receive more or less, wherever you are in the world, the same consultation. So generally, when you rupture the membrane, this is confirmed at when you go to triage. And then the management is generally to admit you to the hospital. They're going to tell you many things about what kind of complication you can have, that are infection, abruption of the placenta, prolapse of the cord, unfortunately preterm birth, infection in your body, that is maternal sepsis. And to try to avoid all these complications, we are put in place a lot of monitoring. That means that we're doing fetal tracing, we do ultrasound, we check your temperature, your heart rate, any precocious signs of infection. We give you antibiotics, and depending on the gestational age, we give corticosteroids to promote lung maturation of the baby. But unfortunately, despite all these interventions, what we know that 50% of the mothers that rupture the membranes, they deliver within 7 days. And it's very hard for us to know in advance, when we have a mother with rupture of the membrane, which one is going to deliver in 7 days or deliver after then. And of course, then you have to consider that there are many consequences to the baby that are not only related to the prematurity, but also related to the fact that the fetus is exposed to a sort of inflammation constantly, and this may cause more complications, particularly to your to the lungs, to the brain, and to future neuromotor ability. So unfortunately, despite this is an old condition, despite we've been struggling with this condition for many, many years in our practice, the advance of our practice is very low. And this is why Isabelle and I were struggling every day to try to find something new to propose and something better to do. One of the major culprits, and it's recognized, is the presence of infection and inflammation inside the intraamniotic cavity. And this was the results of many studies that actually sampled the amniotic fluid through an amniocentesis at the time of the PPROM. And it's calculated that about 50% of patients that presented with PPROM, they have intraamniotic infection or inflammation. 70% of them, they have the same condition in labor, meaning that sometimes the infection and inflammation is not the real primary cause, but it's the consequences of the fact that with the rupture of the membrane, the intraamniotic cavity is a little bit more vulnerable to have a vertical ascended infection. And so this is the main condition. And we believe that everything is a kind of a continuum, if you think about it, that when the intrauterine cavities is colonized by bacteria, progressively this bacteria can affect the placenta, can affect the babies, and end up with all the consequences to the neonatal sepsis. And when your baby is born, you have severe complication.
So Stefania and I, we have worked together to develop this guideline, which has been published by the Society of Obstetrics and Gynecology of Canada, to guide our colleagues in the management of PPROM and try to standardize the practices. So the first step in the management of PPROM is the diagnosis. So sometimes it's really obvious. So you have amniotic fluid leaking through the vagina. It's like water falling from the vagina. So it's really obvious. But in some other situations, it's more tricky. And so we do start by an exam using a speculum to look for amniotic fluid pooling. But then if there is no pooling, we have some other tools to help us. The first tool is a tool looking at the actual pH inside the vagina. And the second one is looking at the crystallization of the vaginal liquid on a slide. This is what we call Fernie. You can see that on the right. Even this test might not be enough to say whether or not there is a PPROM. So there are also tests based on immunoassay, so it's more immune-related test that can be used. So it's a biochemical test that we use. We do swab the vagina first, and then we put the swab in a little tube, which show like a little bit like a pregnancy test, whether or not the test is positive and negative. Sometimes we also use the measurement of the amniotic fluid around the baby to confirm the absence of PPROM, but we mostly rely on this vaginal swab to make the diagnosis. These are the tests that are the most sensitive to make the diagnosis. It's really important to exclude PPROM when there is vaginal discharge, because as Stefania highlighted, PPROM can link to severe complication, and there is interventions that we should do if there is a diagnosis of PPROM.
Okay, so when the diagnosis is established, as I told you, generally what we do is to admit the patient, and it's recommended to try as much as possible to apply an expectant management, meaning to prolong the pregnancy safely as much as possible. Of course, there are conditions. For example, if the patient presents in labor in the few hours after PPROM, or if there are severe signs of infection, because what I didn't tell you is that unfortunately, despite the intraamniotic infection is in the amniotic cavity, there are generally no significant clinical signs of infection. So very rarely the mother develops fever, but if this is the case, that this is a condition that requires to expedite delivery. Or if there are signs, for example, of placental abruption, or unfortunately other severe complications such as cord prolapse. Or if the baby starts telling us that is not feeling comfortable in the wound, and then generally is why we are doing the fetal monitoring. So if we exclude all these conditions, what we do is to try to prolong as much as possible to reduce the prematurity. And this is happened most of the time in hospital. And the interventions that are, as I told you already, suggested are antibiotics, corticosteroids, and when the delivery becomes more imminent, depending, of course, on the gestational age, we promote the use of magnesium to reduce the risk of cerebral palsy. Of course, when PPROM occurred very, very early in pregnancy, in what we call a pre-viable condition, these are like situations that are very, very, very particular and are generally managed in by MFM, a very high specialist for premature babies, so an ICU specialist. In general, when PPROM occur between 24 weeks, 23 weeks, that is the viability, and 34 weeks, what we do is to do expectant management. I'm telling you about inpatient because sometimes if you are the lucky one that can prolong the pregnancy more than 7 days, sometimes this latency, that is the time between rupture of the membrane and delivery, can be even a few weeks. And this is when hospitalization become very stressful also for mothers. So we recently published a meta-analysis because there are many groups in the world, particularly in Canada, in France, that are trying to promote outpatient management. So patient, after being monitored for at least 7 days, they offer to go home and to do weekly assessment in the hospital. Of course, this is depending also on the geographical setting of your country. So for example, Toronto is a huge city, so it's very difficult to arrange this kind of outpatient management because the patient is calculated that it's safe for the patient to be at maximum of 30 minutes away from home. And so sometimes we created these situations such as hospitality. So the patient is actually not admitted in the hospital. Well, we have some facility inside the hospital that they have a kind of a hotel setting that is less stressful for them. And by reviewing this paper with all the limitations that the majority of them, they're retrospective patients, we could prove that actually the latency of the patient that were offered outpatient management was a little bit longer, and there was even less risk of infection. And on the other side, they have the same bad events, either the group that was inpatient or outpatient. So this might be an option to consider and less stressful for moms.
Another important point in the management is the antibiotic regimen that we need to use. So Stefania and I have been reviewing all the scientific publication related to antibiotics to try to choose the ones that are the safest and also the most effective to prolong the pregnancy and to guarantee better outcomes for the babies. An important point that has been shown in our review is that these antibiotics should include a coverage of group B streptococcus. So this is a bacteria that a significant proportion of women have in their vagina without having any symptoms. But when the water are broken, this bacteria can go up and infect the baby. This kind of infection can be really dangerous for the baby. So it's really important to protect the baby against this infection through IV antibiotics or oral antibiotics. Another category of antibiotics that we should use is macrolide, which is given orally and is a category of antibiotics the most effective to prolong pregnancy. In the past, in Canada, we used to have erythromycin, but this is no more available. So now we use azithromycin with similarly good outcomes. The good news is that azithromycin is much more well tolerated by pregnant women compared to erythromycin. And because it remains in the system for long, only one dose or 5 days of treatment are enough to protect the woman. So we have surveyed several centers in Canada to look at the practice to make sure that this practice fit with what is recommended right now. And the good news is that most centers actually used macrolide as a first-line treatment. but the coverage for GBS was not present, so for group A streptococcus, was not present in all centers. And there were also a few centers that didn't use macrolide at all. So it shows you that there is still space for improvement and that the guidelines that we published need to be broadcast to make sure that everybody uses the right antibiotic. We also have compared the outcomes of pregnant patients across several centers in Canada, depending on the type of antibiotic that was used. This retrospective review is submitted for publication, but not published yet. I know it's a complex table, but just to summarize, what I can tell you is that the woman who received a macrolide plus an antibiotic protecting against group B streptococcus were the one who had the longest latency, which is shown in the first column here, compared to women who received no macrolide at all, or only macrolide without a coverage for group B streptococcus. So this confirms the decision that Stefania and I have made regarding the guidelines. In this study, we also have looked at the outcome of the newborn, because it's not only important to prolong pregnancy, but what is important is to protect the babies against infection and long-term complication. But the number of cases in this study were not high enough to demonstrate any difference in the outcome. So this is need to be followed up. But I want to recognize here that our goal is not only to prolong pregnancy, but really to assure the best outcome in the newborns. So quickly, before going into our new project, I want to discuss the management of women who have experienced a PPROM in the previous pregnancy. So first, the good news is that most of these women are going to have a term delivery at the next pregnancy, even if they are at high risk. So 64 to 76% of them will have a term delivery. But they should be managed in the high-risk pregnancy clinic by maternal fetal medicine specialists to make sure we can assess and act on any risk factor for subsequent preterm birth. So, for instance, we can screen for bacterial vaginosis, which is a kind of infection that you can present without having any symptom. And so it's just a vaginal swab that we can perform at the beginning of pregnancy. If this bacterial vaginosis is demonstrated, there is an antibiotic treatment that can be given. We also usually perform cervical length measurement to make sure there is no risk of recurrence. So the shorter the cervix is, the more important is the risk of preterm birth. And if the cervix is really short, we can give progesterone in the vagina to prevent the recurrence of preterm birth, or even perform a cervical cerclage, which is a small intervention to prevent preterm birth. So these women who have had PPROM should be monitored very closely to make sure we don't skip the interventions that should have been done. But there is no reason to give progesterone if the cervix is long in these situations. The next and really important point in the management of a pregnancy after PPROM is to make sure that the woman has good health habit and also support her and support her mental health, because it's really stressful when you have had a pregnancy complicated by PPROM and you're pregnant again. I've had very good stories with patients who couldn't believe how big their second baby was compared to the first one. But through pregnancy, it's really difficult to focus on the ongoing pregnancy without focusing on all the bad experience that had happened at the first time.
Okay, we're going to move forward at this point and trying to, so Isabelle and I, we've been working on together for, at this point, I think probably 5 years since we started looking at antibiotics guidelines and trying to make it better. And finally, we actually started thinking about what kind of antibiotics actually we can use to make sure that prolonging the pregnancy is safe, and also how we can reduce any infection to moms and babies. And this is the reason why we designed this trial that is called Prometeo. Prometeo in Italian is the god of the fire, and it's Prometheus with TH in English. And the purpose of this trial is try to promote a better antibiotic treatment, because the major problem is that the current antibiotics that you have seen in the guidelines that we published reflect studies almost 25, 30 years ago. And of course, as you can imagine, the bacteria can change. The bacteria can become resistant to the normal antibiotics. And also the panorama of infection has changed. So, for example, newborn in ICU, they have sepsis mostly from this subgroup of bacteria that are called gram-negative, specifically a bacteria that is called E. coli, Escherichia coli. Why? And also this is true for moms. And so it's possible that these old antibiotics are not anymore effective to protect moms and baby during PPROM. And this is the reason why we designed this trial with the help of, you cannot imagine how many people, with the help of infection disease doctors, with the help of neonatology, with the help of statisticians, with the help of epidemiology, microbiologists. And of course, we hope also with the help of you, moms, and the Canadian Premature Babies Foundation, because what we want to do is to work together to try to see as a first step, if this trial is feasible, and this is the purpose of this first step pilot trial. So what we want to do is to try to explore if it's possible to randomize pregnant patient with PPROM between 23 and 34 weeks to a standard treatment, and with the new treatment that includes an antibiotics that are more effective, particularly with this new bacteria, a certain number of patients in 1 year time. If we prove that this is feasible, of course, the next step is going to be to design a larger trial, because we need a very large sample size of moms, but mostly of newborn, to make sure that there is actually a benefit in enhancing this antibiotic treatment. So this is why we really hope in the help of the Canadian Premature Birth Foundation, because we need to work all together to try to understand what is the best treatment for these babies.
Another avenue of research of our group is probiotic. So it's a really interesting avenue and very surprising to me, because we told you that we are trying to avoid infection. So why bring new bacteria in the issue? But actually, there have been some studies showing that giving probiotics to women who had PPROM could prolong the pregnancy. There are also a lot of studies about the benefit of probiotics for vaginal health, especially for women who experience recurrent infection. So we have a project that will start soon of another randomized control trial. So the protocol is to give women either probiotic or placebo after PPROM, and to see if there is an improvement in the infant outcome and in the latency period, so in the duration of membrane rupture. This study will be in 8 centers and should randomize 200 participants. And even this study is still a pilot, meaning that with 200 participants, we will not be able to demonstrate an effect on infant outcome, but we will be able to demonstrate the safety of vaginal probiotics and its ability to prolong pregnancy. We will need a second study to demonstrate the impact on the children. But for me, it's really exciting because it's a new avenue. We have been using antibiotics for more than 20 years now. So we know it works. We know that we should improve antibiotics. But probiotics are quite new in OBGYN. Probiotics are used in newborns and especially in preemies with really good outcomes. So we hope that with this study, we will demonstrate its safety and potential benefit for women and children. Now we want to thank you for listening to us, and we are looking forward to your questions or your comments.
Thank you so much for your presentation. I was taking notes as you were talking, so that's why there was a bit of a delay there, because it's so interesting where this is all going. I think when you say there hasn't been a lot of progress made, when you kind of have that glimmer of hope that progress can be made, then it is, as you said, very exciting. So I do have a few questions, and since we ended with talking about probiotics, that's where I'll start with my question. And I'm just wondering if that will be used or could potentially be used as a preventative measure for all pregnant people, or whether this really is a targeted benefit.
So for this study, it's going to be only used for women who have PPROM to see if it can improve their outcome. But your point is totally right. So probiotics are used to improve vaginal health. And we know that dysbiosis, so the disbalance of the bacteria in the vagina, are associated with PPROM. So it's really possible that by giving probiotics, it could be a way to prevent PPROM. But there is no demonstration of this, but it's really likely.
It's that one step at a time, kind of seeing exactly how it affects people's pre-prom first. The other thing that I have as a personal question, I suppose, is that when I had PPROM, I was put immediately on bed rest. And at the time, they had said there was no evidence to say that that is effective in any way. Are we still in that place of not knowing whether that's beneficial or not, or has it been discovered one way or the other?
No, there is no benefit in bed rest. This is true for many complications in pregnancy. So in reality, the bed rest is associated even with, aside from a psychological aspect in moms and high risk of depression, as is probably well known to everybody, but also even to a lower placental function. So babies are smaller, for example, in patients condemned to bed rest for a long time. Now, there is no evidence and there are no benefit. Actually, there is an increased risk of clot in pregnancy. So it's important, I mean, not to run the marathon when you have PPROM, of course, but generally to have like minimal activity. And there are basic science studies, very interesting, that shows that minimal activities, even in patients with prolonged bleeding or PPROM, they have less inflammation factor. So they have less inflammation than patients in completely bed rest. So it might be true.
Sorry, did you have something to add, Isabelle?
In my center, we are really trying to promote women to move. So, for instance, we have a video from physiotherapists to help to guide women to better understand what kind of movement will be appropriate. Because of course, in situation we're not going to ask women to run, but there are activities that can do on their bed or even on the sofa, which are really safe and a good way to move despite this complication.
I did pop up a comment there from A.G. Hetty, who said, thank you so much for such excellent information. I delivered a 23-week baby, and now I'm scared of being pregnant again. I'm sure you guys hear that a lot. I was diagnosed with endometriosis and told I will be put on antibiotics with my next baby. I know this is something that you talked about a little bit in your presentation there, that it is something, and I alluded to it in the intro too, that once it happens one time, people are afraid it's going to happen again. And you talked a little bit about the prevention. Is this one of those things that we talked about antibiotics as well, but is that the way to go with something, for example, like endometriosis?
So Stefania, if you want to add something, just let me know. But usually endometriosis is not a reason to receive long-term antibiotics during pregnancy. There is another complication, which is chronic endometritis. So it's chronic inflammation within uterus. That can be a reason to receive long-term antibiotics. But usually we try to treat before pregnancy and make sure the inflammation is gone before starting new pregnancy.
Yes, the actual evidence is to treat infection, even like the bacterial vaginosis, for example, that Isabelle mentioned before. So definitely these are pregnancy that they're gonna go more investigations, even during the course of the pregnancy, or ideally you should treat before, but even during pregnancy, you double check that there are no concurrent infection. And I think probably instead of endometriosis was endometritis of chorioamnionitis, that these might be the complication associated with prematurity. One of the most important, so for the primary prevention, we have a very few indications. What is very helpful, it seems very helpful, is to be patient and to wait at least 8 months between the two pregnancies. The inter-pregnancy interval, this is what we generally promote, because it's also actually easy to imagine that the body needs to, recover from stressful events, that it was not only for a premature baby, but also for mom. And so we generally try to promote this interval of time that is actually also helpful to try to understand and have an histological exam of the placenta versus understanding if there are any concurrent problem in moms. So sometimes many investigations, like even the easier that you can guess, like the shape of the uterus of moms, if she has any other concurrent risk related that we can discover. So 6 to 8 months is what we generally suggest. And then of course, I try to be as healthy as possible. So try to have a very good diet in general. Not that you were guilty before, but what I'm saying, trying to be very healthy, to stop smoking, for example, if you were smoking. So these are the interventions that we know that can improve. Even the omega-3, they're like not super strong evidence, but if you are in a country that you, for example, you don't have blue fish in your diet, they're not deleterious. So you can add in your diet omega-3. And these are all strategies that can you put in place even before the following pregnancy, and definitely being followed in a high-risk center.
And you also talked about progesterone. Oh, sorry, I have another question there too from AG, so I'll make sure we get that in. My last question. So since it's chronic, it can be treated before the next pregnancy. Oh, very good follow-up question. Yes.
So I guess this is about chronic endometritis. So yes, it can be treated. So it's a treatment usually of 2 weeks of antibiotics. And then it's important to get a new test to make sure this inflammation is gone. But we really try the definition of chronic endometritis and how it should be managed. It's still something that is under development. It's a new problem to us, but it really makes sense to make sure that you are treated and that the treatment worked before trying to be pregnant again.
So my next question was about progesterone, because that was something, again, that I had experience with. I have 3 babies, and my first was our Preemie. And so for my next pregnancy, number 2, I was put on progesterone. And I saw it as a prophylaxis, but it sounds like from your presentation, and maybe I misinterpreted, that it should only be used if the cervix starts to shorten.
Yes, exactly. So I don't know when was your second pregnancy, but the truth is that the evidence changed and the guidelines have evolved. So we used to think that progesterone was effective at preventing a recurrence of preterm birth, but now we know that it is only effective when the cervix is short. If there is no short cervix, it's not really clear that it's effective. Of course, it's usually well tolerated, this treatment, because it's a vaginal treatment, but still there are costs associated with the treatment and sometimes side effects. So we really try to find the good treatment for the right patient and not treat everybody the same.
Well, it was a decade ago, so that makes sense to me.
No, absolutely. But I can tell you that there is a huge debate among giants of preterm birth, because recently it was published in one of our specialized journals, like a debate between 2 big names about treating everybody with progesterone despite the length of the cervix, or just treating once the cervix is shorter. So it's still under debate, to be honest. And I agree with Isabelle. Probably we should. The secret is to monitor the cervical length during the course of the following pregnancies. And even if we're noting a certain shortening, despite the absolute number, it's probably meaningful to start progesterone. Probably not by default, but it's still a huge debate.
And this is one of those difficult things, because you want something to be done. And so, like I said, I delivered my first at 28 and 1. And so then when you're pregnant with number 2, then it's difficult to not do anything but to wait and see. I was very closely monitored, but if nothing else, that progesterone, I felt like, gave me a little hope that maybe it'll just help the pregnancy last longer, because it's this very unique world, I guess, of medicine, where sometimes it's better to not do anything, to not do the interventions.
Yes, you're right. And also for us as physicians, sometimes we want to have something to offer. So it's also challenging for us not to do anything. But we have to weigh the pros and cons of any intervention. And I think, we have been talking about personalized medicine. And this is, I think, the way to go. So rather than treating everyone the same way, we should really look for signs and maybe biomarkers to really give the appropriate treatment to the right patient.
You had talked about the 50% number of those who, if they go longer than that, 50% go shorter than 7 days, 50% go longer. Does that longer usually go into like a term length, or is it still something that often with the rupture it's premature?
Very rarely term. So, but the problem is it's completely unpredictable. So we have a good data to say, okay, the first 7 days are very important, but sometimes you can see the prolongation of pregnancy over 7 days and then 10 days and whatever. And it's very difficult at that point. We try to publish. I publish very small studies on trying to see if some markers in the maternal circulation can be predictive. Mm-hmm. You can have some evidence at 7 days. It's very hard to say. And this is frustrating because, of course, you have all these patients admitted in the hospital. You see them in the morning when you're doing your rounds. And then sometimes the morning after, you see them delivered. And this was completely unpredictable in the morning before, because then labor can start anytime, or complication like infection, fever, and you have to intervene. So this is the frustrating part. And believe me, it's for you, but also for us, because I would love to be a better physician for my patients. And this is why we have this motivation to try to do our research as much as possible to try to find some answers.
If I can add, in our retrospective review of Canadian data, in the group of women who received the antibiotics that we are recommending for now, the mean latency was almost 16 days. So it was actually much better.
Yeah.
And for me, it was really reassuring news that what we are doing is actually improving the latency.
Yeah.
There is still room for improvement. And as was saying Stefania, we have women who actually go until 37 weeks, and we have to induce them. So it happens, but the risk is still there, even after 7 or even after 14 days to deliver.
Well, thank you both for joining me today and for sharing your knowledge, your wisdom. I truly feel this is a very brave field that you're both in, and that you are exploring to make families just thrive in their pregnancies, and of course in NICU as well. And so thank you so much for sharing your knowledge, and for, I think, giving people hope that there are people like yourselves who are really looking for the answers and for better solutions and better possibilities for people who are looking to be pregnant in the future. So thank you so much for joining me here today.
Thank you. Thank you.
And thank you, everyone, for joining me online as well for this edition of Preemie Chats. A special thank you to AstraZeneca for their ongoing support of educational programs such as this one. And just a reminder, again, that if you missed any part of today's session, if you want to rewatch it, or if you want to see any of the past editions, then please go to canadianpreemies.org. You'll find a whole library of Preemie Chats there, covering a variety of topics. You'll also find many resources and support options available that are free for you to use for yourself or for your units. And you'll be reminded that CPBF is a charitable organization, and it depends on support to continue its important work. Think about how you fit in supporting CPBF's mission in empowering families of premature babies in every step of their journey. Together, we can create a brighter future for all preemies and their families. I'd invite you to join us here next Friday at 1 p.m. Eastern Time as we talk about learning how to feed your baby in NICU. That is a hot topic, so be sure to join us for that. I hope you all have a good and quiet weekend.